Thank you for joining us. This is Russell Hendrickson with PDS. Joining me today is Becky Cook, who's on the line as well. And we'll dig right into today's topic and make it useful. So first off, if you're not familiar with PDS or Practical Data Solutions, we are a company that specializes in healthcare analytics, dashboarding, business intelligence, and data warehousing. And we've been working with healthcare organizations for more than 20 years in these areas, the very things that we're going to talk about today. Just another quick slide on who PDS is. You know, there's lots of technology in the marketplace today. Analytics is kind of the buzz, especially visualization in analytics, and certainly that's a topic we're very familiar here with PDS. But what really has made PDS successful over the last 20 years, and certainly all of the customers that are on the line here, thank you for joining us and thank you for being a customer, is really our ability to join and blend technology, leading-edge technology, with programming and business intelligence experts on our team, with content experts that understand healthcare, have managed and worked directly in the healthcare setting using information and in driving best practices. And when you put that with our experience and our proven methodologies, that really has been what's made PDS successful working with our customers. So just a little bit about PDS and what we do, and certainly in today's webinar, as you'll see, we're going to blend content around the topic of risk scoring and HCCs with the technology and how to be effective with the changes coming in the industry. So with that, as I mentioned, for the next 40 minutes, we're going to talk about risk agreements and how many fee-for-service risk agreements are using HCC diagnosis coding. We're going to explain how it can be converted into higher payments, and understanding some of the barriers and the challenges with working with this data and turning it into usable information for managing effectively. Ultimately, we're going to look at how patient care caps can affect your reimbursement, and then we're going to share different strategies to best manage through this technology and take advantage of it. So with that, the first thing we're going to do, I'm going to share up on the screen, and I'd like everybody to respond. If you would just take a minute. So let me throw the poll question up. Does your practice currently have contracts which use a risk score? And hopefully your screen popped up there. Good. So we'll let you answer in on that. Again, over on the right side of your screen, you should have had a poll question pop up. So while you're answering that question, I'm going to continue on here. I'd like to introduce Becky Cook, who is an executive consultant who works with PDS. She brings significant experience in revenue cycle, clinic operations, and all of the related areas around healthcare and best practice management, and her experience that directly relates to today's topic. She worked as a CFO at a large employed and IPA physician group in an integrated health system. So with that, Becky, I want to turn things over to you.
All right, thank you, Russell. So why do we need risk scoring? I thought that was a concept only for ACOs. Well, as it turns out, as I'm working with contracts from Cigna, United, Aetna, and Blue Cross and Blue Shield, all of those payers are using scoring when building even their fee-for-service contracts. The insurers are calculating their risk-adjusted cost of care per patient and determining who are high or low-performing physician groups and what those fee schedules will be for even fee-for-service contracts. Where we're seeing a lot of risk-based scoring, though, is with value-based contracts, where the practice is at risk for earning incentives and identifying and prioritizing patients who require more or less care than average. So even if the care managers are being utilized, the practice needs a comprehensive review to make certain that all high-risk patients are identified, and we can do that through an internal risk scoring methodology. So there are various risk scores methodologies that can be used. We have now HHS HCC, we have CMS HCC, we have MARA scores, which is a proprietary system from Milliman. Another example is the Johns Hopkins model developed by Johns Hopkins to project who's likely to be needing advanced interventions. PDS has elected to use the HCC models for a couple of reasons. One is that it's readily available. It's being used by CMS and HCC, who are approximately covering 43% of all of the insured population in the U.S. So that's a huge share. They're really the elephant in the room, so to speak, for using HCC. And I expect over time there will be more and more shifts to using HCC scoring. So what are some of the key steps to building a patient risk profile? Russell, let's talk through what it actually takes to build a patient profile and compile the patient profiles into a practice score. Now, I'm going to use a CMS HCC example today. So the first thing that we have to do is to gather all the diagnosis codes for each patient for the calendar year that we're working with and eliminate all the duplicate codes. Then each unique diagnosis code is crosswalked to the HCC table to determine if there is an HCC assigned for the diagnosis code. So here's an example of what the diagnosis codes with HCC 19 look like. You can see there's a variety of scores that are assigned to HCC 19 for 2016. Next, we need to add the disease coefficient for each HCC category. That's stored in a separate table that's available on the CMS website, and it needs to be matched to the diagnosis codes by use of the HCC category. So all diagnosis code in HCC 19 are grouped, and then the coefficient is assigned to the patient. Note that there's only one diagnosis code. Each diagnosis code is assigned to only one HCC. Some chronic conditions such as diabetes have hierarchies that are then applied to eliminate double counting of HCCs. For HCCs, we'd call this bundling or content of service. So if a patient has two diabetic diagnosis codes, it might be that both of those are assigned to the same HCC, and we would, through the hierarchy, eliminate the unneeded one. At that point, we're ready to add the gender and age coefficient for each beneficiary. So we need to start with calculating the Medicare age for that patient. So the Medicare age is the patient's date of birth for the year, you assign the year, and then the payer is assigned has assigned a determination date. For Medicare, that's February 1 of each year. So the patient's age is their age as of February 1 of the claim year that you're working with. Then you can look up the gender and age coefficient from a separate table supplied by Medicare. Then we can sum the gender, age, and condition coefficients for each beneficiary to come up with a total score for that patient. We need to also maintain the individual components because we're going to use those as we work with some of the data. And finally, the patient disease, age, and gender score is summed for all the patients and averaged by either physician, payer, for the practice, and combinations thereof. So that's a rather simple and straightforward explanation of it, right, Russell? Can you go through how PDS would deal with the data calculations we need?
Crystal clear, right? It's just a bunch of math. So if you're familiar with PDS, there's kind of three main ways that I like to say we help different organizations. One is helping customers get answers. Two, then illustrating it or presenting it visually. And three, distributing it and getting it provided out. So this is a great example of where we really need to get answers. And getting answers can be somewhat challenging at times. Obviously, the complexity of scoring requires that we can pull the claims data, have all the diagnoses, all the visits, all the transactional data. We are going to need a relational database. Now, for smaller practices, you probably don't have these type of resources or skills on your team. If you're a larger organization, you may be very comfortable working with tools like SQL Server. Certainly for them, we're going to need to extract the data, We're going to need to be able to pull the diagnoses and the visit data in, and we're going to need a database programmer who's comfortable working with the data sets to stage and calculate the various columns to get the HCC scores to roll, to calculate the primary or the secondary HCC scores, and then to bring in the age coefficients and do the final calculations. Once you've done it one time, obviously then to be effective, you're going to want to be able to automate that and refresh it. So as much as overall what Becky walked through is fairly straightforward, there's a lot of nuances to that, and it's going to take at least having these tools before you could consider building something like this on your own. With that, I'm going to just show you very briefly what that might look like when we bring it up and put it into a tool set. So let me switch over here before we get to the next survey question. All right. And what I'm going to do is I'm going to jump into our HCC data set, and I just want to show you the impact or what we've done. So now what we've done is we've brought up that data that's been staged in our SQL database. We've stuck it into an analytics tool. And what we can see now is I can look across the data, and I can look by payer or plan. And I can start to see then, by provider, who are the patients, and what are the patient's scores for the current year and the prior year, and how those scores sum. And in just a minute, Becky will dig in and say, okay, what do we do now that we have this data? How do we actually work with it? Before we get to that, though, I'm going to publish and launch another poll, and I apologize before I didn't hit the poll open slide. So you should now have the second poll. Do you currently have shared savings or incentive-based contracts? Do you have them with Medicare, Medicaid, commercial, all of the above, or none at this time? And I believe if we set this poll up correctly, you can pick more than one answer here. We'll give everybody just a minute to answer that question. I see a number of answers coming in right now. About 45% of our participants are saying yes to all of the above, so commercial, Medicaid, and Medicare. About 20% are saying they have just Medicare Advantage, and about 25% of folks on the call here today are saying no, we don't have any shared savings or incentive-based contracts. So we'll share the complete results at the end of the poll. Excellent. Okay, we've got about 80% of people voting there. So I'm going to close out the poll here. Becky, I'm going to turn it back over to you and say, okay, we've got the data staged, we've structured, we've got it all set up. I'm ready to hand it back to you and say, how do we use, what should we be measuring? How do we make this information effective now to help us get answers?
So I touched briefly earlier on how insurers are using risk scores for fee-for-service contracts. And here's an example of how total costs for the patient are adjusted by the practice overall risk score. It may be that your contract rep is not sharing this information with you. If they're not, I would certainly ask for it. But what I find is that they are now starting to share the risk adjustment factors and the risk scores for the population in order to, as part of the contracting process. So the practice in the lower left quadrant has a cost per patient of $13,000 per patient. That's identical to the practice in the upper right quadrant, who also has a cost per patient of $13,000. The practice in the lower left quadrant has a risk adjustment score of 0.92, so that is lower than average. My guess is that that practice hasn't started working on their risk scores and is not aware of the impact that their diagnosis coding has on even fee-for-service contracts. So if you divide the $13,000 cost by 92%, the result is the risk-adjusted cost of care, or $14,130 for their 5,000 beneficiaries. Compare that to the practice in the upper right quadrant and notice that the risk adjustment is 1.13, or higher than an average of 1.0. The overall impact of chronic conditions is but the unadjusted cost of care is the same, the $13,000. So dividing the $13,000 by 1.13 results in an adjusted cost of care of $11,500. If you know that information, you can then use that during your contracting process for both incentive contracts and fee-for-service to see what incentives or fee schedule changes the payer is willing to provide as an organization. So one of the things that we also want to do with our risk scores is to identify gaps in our patient care. And not the clinical gaps, but the financial gaps. So we want to review the insurer's beneficiary list against our list of patient HCC scores to try and identify any missing patients from the practice or adding patients to the insurer's beneficiary list who we believe should be assigned to the practice. We're going to review the insurer's risk scoring and their HCC list against the practice calculation, looking for missing HCCs from the insurer records or from our practice list. And it's frequent that we find that the insurer does not have some of the HCCs that we do, where we've collected information from specialists or other sources that the insurer has not yet picked up. We're also going to use a suspect and gap report to identify patients who need appointments and getting them scheduled for care, or to identify missing diagnosis codes for the current year. And then we're going to review our quality metrics report against HCC scoring. The last thing that we want to do is to do a lot of work around collecting quality metrics and then find out that we don't have diagnosis codes submitted for a particular patient, and to leave those incentive payments or the scoring on the table and not get it accounted for. So we're going to flip back here to some reports that we have compiled to show you what a couple of these reports might look like and how we would use them to review our data. This is a suspect and gaps report, and you see some red highlighting, yellow highlighting. We're actually going to use that information to help us narrow down patients that we want to review for gaps in care. As we look at patient Lisa Scogan, which is the first patient here on your screen, we've honed in on the fact that Lisa is a patient of Dr. Ann Morgan's. She's covered by Humana. She has a diagnosis of diabetes. And now we can look at just Lisa's information. You see that we have 2014 and 2015 data available for this patient. You see that she also has HCCs 18 and 19 across the top of the table. Those are both diabetes HCCs. And this is an example of the hierarchy that gets applied to our patients. You have the option with this particular report of looking at all HCCs or only looking at the primary HCC or looking at the superseded HCCs. So this makes it easier for you to build the type of report that you want your care coordinators and coders working with, or your schedulers working with, to make sure that the correct patients are identified for them to work with. You'll notice here that 2014 has a yellow square there, and it's labeled prior year suspect. If we look at the HCC coefficient, it's 3.68 for diabetes, and that is the highest level of diabetes score, as opposed to 19, which is assigned at 0.118. Medicare will not allow for those to be added together. It eliminates the HCC 19 as being content of service of HCC 18. That prior year suspect is there because if you look at the HCC change from prior year, which is what that column is directly under the 18, you'll notice that it is the same value as the HCC coefficient. So there was no prior year diagnosis of diabetes. We would flag that HCC as a prior year suspect so that you can confirm that there was no diabetes diagnosis that should have been coded in the prior year. If you look at the next line in 2015, you'll see that it is a current year suspect, and that there is no HCC assigned for the current year. Since diabetes, particularly complicated diabetes, doesn't go away, we would look at that as a current year suspect, and we would want to check to see if the patient has not been in or why we don't have their diabetes coded for this year. So that's our suspect and gaps report. We're also going to look at a report that gives us the ability to start planning with our physicians for how much work they need to do. This is particularly helpful when you're just starting to work with HCC categories where you don't have very good historical data. You have a lot of unspecified codes. So this report gives us a list by physician of the number of HCC categories that they have to work with. In addition, we have the HCC counts, which is just a count of the total HCCs that the physician has, and then a unique count so that they know how many unique counts that they have to look at in a particular time period. So useful for working with the physicians in terms of prioritizing who you need to work with and who the coders need to work with, for example, to make sure that they're getting their diagnosis codes captured adequately. All right, so we heard a couple of ways that we can use risk scores. One of the biggest ones is being able to identify outlier or at-risk patients. Simply being able to line up the risk scores for the patients and stratify your patients based on what their HCC score is. You can set those at any level at which you wish, 5 and 10 perhaps, so that patients who have an HCC score higher than 10 are assigned a different priority than those with 5 to 10 for a score. You can use your care managers then to organize their work around those high acuity patients and make sure that they are being seen appropriately by your physicians and nurse practitioners or VAs. In terms of contracting, what we've seen is verifying that risk score from the insurers, as well as being able to use the information on risk scores to be able to negotiate incentives from insurers or higher fee schedules if that's available to you. So some of the barriers that I've seen to using risk scores, probably having insufficient diagnosis codes on the claim forms. Now, we haven't had payments based on diagnosis codes before the last few years. So there are a lot of physicians still using unspecified or inaccurate diagnosis codes just out of habit. That's what they used the last time, so that's what they pull forward from their notes this time. Or the diagnosis codes are not easily accessible to the physicians as they're filling out their encounter. Having those diagnosis codes loaded into the problem list, the chronic diagnosis codes loaded into the problem list, makes them accessible and easy for the physicians to copy into their notes or to assign to the visit for that day. We have lots of staff who's not been educated on risk scores. The coders in particular, it is a different skill set to do HCC coding than doing normal coding for primary care. They do need additional education. They need education specifically on risk scores and HCCs and how to coach the physician on making sure that their diagnosis codes are specific enough and that they are reflecting the patient's medical condition rather than just a general diabetes diagnosis code, for instance. I also don't see many of the EMRs providing information on risk scores. They're providing some information, but not specifically calculating risk scores, which is really important to understand on your patients. And then on our contracts, working with the payers, the biggest thing I see as a barrier is a lot of the data is not coming back on a timely basis. The United contract that I'm working with right now indicates that they will provide quarterly reports 90 days after the end of the quarter. The fact that that data is coming back after the fact just doesn't give us enough time, especially at year end, to be able to schedule patients in for visits and to get all that accomplished on a timely basis to get all the diagnosis codes submitted. So we have another quick survey for you. Russell, if we can go to the survey.
Should be popping up on your screen right now. There you go.
All right. So we're going to ask how you're managing patient populations with HCC or risk scoring. I'm going to pause just a minute so you can read the responses there. And then I think we'll go on to share with you another type of report that we've put together to illustrate some sharing information with our physicians and with our staff member.
So while we're polling here, just to share a few things, and then I'll close the poll there, but we've got about 29% of the organizations are using internally built tools. 16% are using third-party software. About half are using reports that come back from the insurers and the payers. And about 36% are not managing populations currently or with software tools. So we're kind of all across the board on this question. Again, we'll share the final answers out when we get to the end of the presentation.
And that's not unusual. It's hard to find good tools. Many organizations have had to try and build their own, and a lot, especially smaller practices, are simply managing with reports that come from the insurers and payers. What we have here is an example of a physician dashboard. So one of the things we talked about at the beginning was that it's really important to be able to communicate these to our users, to the physicians in particular, because they can make such a difference in your results. They're the ones assigning the diagnosis codes, sharing this with your coders to make sure that they understand that they're impacting our HCC scores. And typically, the staff is very willing to help with this if they understand why and how it impacts the practice and the physicians. So this is a sample dashboard that just shows the physicians their HCC average for 2 years, 2 prior years plus the current year, the number of HCC patients that they have, the unique patients in the entire population so that they understand how many of the patients that they have, the percent of patients with HCCs, and then whether they've attended the practice-provided education, and whether they have had their coding audit for this year, and whether they've passed that audit. So Russell, is there anything that you want to talk about in terms of actually being able to deliver dashboards?
Sure, Becky, thanks. So, from a technology and an analytics side, I think the key things here is, one, do you have an appropriate set of tools to be able to publish information out to physicians, provide feedback? Do you have an easy way to distribute that information, so that physicians can see and in many cases, self-correct their performance? One of the biggest considerations when we work with organizations distributing, reports down to the physician level, obviously, is we're having appropriate security to manage. Typically organizations are allowing each physician to see his or her reports and feedback, and appropriately a practice administrator for that group of physicians can see all of the physician's data, but you typically don't see organizations sharing all the data across the organization. There are some that have very open transparency. In either case, you're from a technology side, your tool set, it's important to have a flexible set of tools that makes it easy to publish out and communicate the information you need.
So let's go to the next report that I have. And this is a report that's built from payer data. So reports that are sent to us by the various insurers. And you can see we have data here from Humana, Cigna, and from our own Medicare Shared Savings Program. Some of this is demographic information, it's clinical quality metrics, but we also have the risk management section at the bottom of the report. The reports that are provided by the payers are typically difficult to share with your physicians directly. You almost always have to transfer the data to some other type of report for them because those reports tend to be very long and cumbersome. They're done in Excel. It's difficult, especially if the physician wants to compare results across multiple payers. So we've brought that information together into a report with our dashboarding tools to look at our risk adjustment factors across both Humana and Cigna and what we've calculated internally from our Medicare Shared Savings Program. It fits well on a dashboard like this because then the physician has the ability to score across their patient population instead of looking at just an insurer's population on its own. And we're looking here for the type of consistency that we see here. A little bit of difference in those risk adjustment factors. I would definitely be looking at the Medicare secondary payers there where the HCC score is less than average and start looking at some of those patients to see. I know we're not treating them differently from a medical point of view, but why do we have a difference in the HCCs? Is that due to patients or is it due to something in our process of capturing data for those patients? So I'd like to summarize some of our recommendations today, what we call best practice recommendations. You notice today that we have pulled all of our data from our practice management or our billing system. That enables us to calculate our disease and age and gender scores very quickly at the end of each month and to update them monthly so that we have those scores rapidly available to us. We can be looking at those scores every month instead of at the end of the quarter or at the frequency with which the payer wants to provide them to us. We've structured the data using the CMS hierarchical condition classification. We have ability to get to that information, to that scoring system very quickly and easily. So we've incorporated that into our best practice recommendations, and we've built our tool sets based on CMS HCC. We have the data optimized to answer questions and ensure that our reporting gaps are clearly identified. So we looked at a suspect and gaps report that helps us identify at a high level where do we need to identify patients, how can we identify those patients to make sure that we've submitted their data correctly and on a timely basis. And by the way, that report can even be used for prior year reporting. If you get to the end of the year and discover that you've had some diagnosis codes that weren't submitted in the prior year, there is a correction period. And so you can even use that prior year suspect to identify items that may be missing from the prior year. And mostly we're going to accomplish much more precise work with less effort by organizing our care teams around our patient management and use of risk scores. So focusing our care managers and our coders on the patients at the top 5% or 10% or 20% for Medicare populations that do have chronic care conditions and need more care than the typical patient. So Russell, some recommendations on the technical side?
Sure, thanks, Becky. So, there's a couple key things here. Obviously, with the payers, not providing data back, frequently, quarterly, or 6 months in some cases. Our best practice approach here is data needs to be updated at least monthly, and so you can continually see and measure your scores. Obviously, as part of that, if you've got a long manual process to try to stage or calculate, that's just not going to be effective. So being able to automate that when the data not only updates, is automatically transformed, it's staged, and then the users have appropriate analytics, reports, dashboards, and we can communicate that out. Right? So it goes back to not only do we need to be able to get the answers, but we need to be able to make them effective and have the right information in the hands of the right people. And ultimately, being able to illustrate, as we call it, or visualize data is critical to being able to focus on the results. And then, as I mentioned earlier, we need appropriate tools and security. Taking that just a little bit further, and Becky mentioned this, how do we get the right information? How could we focus dashboards? At PDS, one of the biggest things that we like to be able to do is tell a story, illustrate what's going on in the organization. Look for the outliers. The 80-20 rule, so much comes into play here. This is an example of a best practice dashboard, and I want to talk about what it's highlighting, and then Becky can walk you through some of the nuances of what we're doing with scoring, but we're actually calculating and looking across all the physicians, and you see we've got quite a report here. The question we're trying to answer or illustrate is, how can we do, the least amount of work and get the biggest impact? And this dashboard is designed and can be updated right from your analytics in such a fashion that by simply clicking a button, we've now identified the 10 providers with the biggest potential areas to increase or improve our bottom line. Right, so this is what we call a predictive dashboard that's looking for performance gaps. And if you would, Becky, I'm going to ask you to kind of walk through the various aspects of what we're measuring here and how did we come to who are the physicians of our population that potentially have the most areas for improvement.
Okay. Under the activity bar at the top, you can see that we've brought in HCC scores from prior year, current year, so that we have that data available to us. In the comparison columns, then, we have ratios of the percentage change in the HCC score, the change in the patient count, change in unique patient count, and number of patients with HCC. So that's all information that will help us evaluate what we really want to go after in this report, which is the improved reimbursement. So how can we understand what the impact would be of increasing or decreasing our HCC scores, our risk scores, based on the physicians that we have? So here we have it set up, I believe, to show the rank of the top 10 maximum opportunities. So those who have the lowest HCC scores, who have a lower number of patients, and how might we capture more revenue based on improving their coding. So if we look at the drop-down box, you see there's select, and under that opportunity per HCC, if we increase our HCC scores by 0.1 or 0.2, we can then look at the impact of that increase based on the average or total revenue per physician. And you can see that number change. We've also looked at what would be the increase in revenues if we can increase our total HCC score by a percentage. So by 5% or by 10%, for instance. And then the third example of improved reimbursement is if we can have or find 1 or 2 more patients or 4 patients who have HCCs that we haven't previously discovered, what would be the impact at our current reimbursement, current care coordination fee? And we can change there the care coordination fee as well. This dashboard is set up so that it can be rapidly changed and you can look at it online. It can be updated monthly. Very helpful as you're working through your budgeting process and your contracting process to be able to understand where your opportunities are. Okay, Russell?
Excellent, thank you. So if I were to summarize a few points, and we've got just a couple other, at least one more dashboard we'd like to share and show. It's critical to understand the financial impact of risk and incentive-based contracts. If it's not impacting you today, or you may not be aware of its impact today, it's definitely going to be impacting you tomorrow and as we move forward. Being able to identify patients and understand where we may not be reporting or accurately reporting and calculating is critical. Obviously, we've seen having analytics and dashboards that can communicate and ultimately identify gaps is critical. And of course, with that information, then we can obviously target and appropriately manage appointments and the associated revenue that comes with that. One of the physicians that we worked with used to say, we need to provide better quality of care. We need to improve, our performance. Oh, and wasn't shy about this. By the way, we will also impact the revenues on the bottom line, and was very open to say, our goal really is to optimize both quality of care, but we should be paid for that. And then, of course, being able to identify, operational risks and the associations with those with patient populations. So I've got one more dashboard I'd like to leave you with. Before I get to that, I'd just like to say, if you're not familiar with PDS, our goal is to help organizations get answers, illustrate those into visualizations, and then distribute that information. If you're not familiar with PDS, we do work across multiple facets of the revenue cycle, physician productivity, patient access reporting, looking at demographics, integrating and blending data, whether it's expense data or patient satisfaction data. And of course, as I just mentioned, these performance opportunities or performance gap reporting that can be run across any of your analytical data sets. But one last report I'd like to share with you, which is indirectly related to today's topic, but I think is important as you think about the changes in healthcare and how practices are being reimbursed, is to be thinking about and understand that physician compensation plans, if you're not already changing them, and most of the organizations we're working with, if they're not having recently changed them, they're actively in discussions and redesigning and enhancing plans, so that as we move forward in healthcare, we're not just looking at RVU-based reimbursement, but we're thinking about integrating and bonusing with incentives or clinic goals, across the organization, and certainly, directly ties into today's topic. This sample dashboard is the kind of reporting that our customers can use, where not only is it showing a physician, here we are through August, and because of where you're performing, on a straight productivity side, we can estimate what your bonus is going to be, assuming you continue on that path. You can also very clearly see that they're hitting their quality score, but they're potentially missing their patient satisfaction score, which, if you look down here, is showing they're missing, the 25% of their available incentive bonus. And that's just another example of how, when you start to think about analytics and communicating, it's important to be able to put all the different pieces of the puzzle together. With that, we have one more survey question, and then we will take questions here. So I'm going to launch that up on the screen, and the survey question we'd like to ask is, did we meet our goals for the webinar? And it's a simple yes or no. Actually, I think I changed it, and I made it a yes, somewhat, or not at all. Certainly, we hope you found this webinar of use. At this point, please feel free to chat in your questions while you're filling out the survey there. While you're completing the poll question there, Becky, we do have a chat question right up on the screen here. It says, we are an ENT practice. The diagnoses we use the majority of the time are not necessarily those chronic conditions. How would these risk calculations affect our practice?
With an ENT practice, I think it's going to be difficult to significantly change your reimbursement or the offered incentives based on your risk scores. I think you're going to have to look to your quality of care scores there in terms of what you're offering to patients and cost-effective care that you're providing to patients. The HCC concept really applies to primary care and some internal medicine subspecialties. So I don't mean to provocate here, but there really isn't a lot of use around HCC for ENT practice, unfortunately. Russell, do we have? Yes.
The question we have is, where can we get copies of the slides? The slides are actually available through the GoToWebinar. You should have that in your GoToWebinar panel. You should be able to download the presentation with the handout. And if for some reason you're not able to get those, please feel free to send us an email, and we will send them out to you directly. But they are available before you log out of the GoToWebinar. You should be able to pull down that information directly. Do you have any other questions at this time? Becky, one of the questions that I've heard in the past came from an organization. They were asking about what happens when you have, you might have had a visit that was denied. Do the payers count the diagnoses when a claim is submitted and then denied?
It depends on the denial reason. If it's denied because it's not medically necessary, for instance, the diagnosis code will be tossed out. If it's denied because of a claim problem or an inadequate diagnosis, the diagnosis code would be included and eligible to include in the HCC scoring.
Becky, we have another question here. How does sequencing of diagnosis codes impact HCC? If we can only submit a certain number of diagnoses per service line, and that's, I know, something I've heard you talk about in the past. Could you share a little more information on that?
Yep. CMS actually allows for 12 diagnoses codes per line. If you don't have the ability to get them on a per line basis, you can submit them on a claim basis. You can also submit them directly to the insurer and ask them to add those to their claims processing system. Generally, if you enter them in the practice management system, then they're available for extraction. So if we were to look at pulling the data out of your practice management system, they would all exist there. They may not be at the line level, at the claim line level, but we would certainly be able to get them out. So we can capture all 12 diagnosis codes. Work with your carriers, because if they're not accepting them, if the private insurer isn't accepting them, they're required to accept 12 diagnosis codes per line, and you can actually add more than that through providing them with an Excel spreadsheet or other means of providing them additional diagnosis codes. That's not unusual for some patients who have multiple HCCs.
With that, I don't see any more questions coming in at this point in time. I will try to share out the poll. The first question was, does your practice currently have contracts with a risk score? 71% of the attendees answered that question. We had 87% of the people online voted on. So most of the organizations today certainly do. Okay. The next question, I'll share out the results here. Do you currently have shared savings or incentive-based contracts? And about 43% said yes, all of the above. Doesn't look like anybody, at least on the webinar today, has shared savings with Medicaid, and about 20% are involved with Medicare Advantage. So kind of a mix. That was with 80% of the people on this webinar voting. And I believe we had over 50 people in attendance, so to give you an idea of the size group we had. The third question we had, are you actively managing patient populations? And it looked like 52%, with reports from insurers and payers. Bulk of users, saying working with insurance and payer reports, and about a third saying, not managing. So now this was a multiple choice question, so we only had about 65% of the people who voted, but it does give you a feel for what others are doing. Becky, I guess you and I will be happy to see that of the 68% who voted, most people felt this was of value, and we certainly appreciate you joining in on this webinar. The last thing I'll leave you with, if you have any questions about anything we've shared related to this or any of the other topics, please feel free to reach out to us, and certainly you can get in touch with PDS here. I know at least one person had chatted in and still couldn't pull down the webinar handouts from the GoToWebinar. So if you do, just feel free to shoot us an email, and we'll get that information out to you within the next hour. And last but not least, thank you, Becky, for putting this together and sharing the information that you did. And certainly to everybody attended, thank you for your time today. I really appreciate it. Have a great day, everyone. Thank you.